Hello, everybody. Welcome to our today's discussion. It's the Wake Up Call: Canada's Long-Term Care Crisis, and wow, we've got about 102 already logged in. My goodness. So today we're going to be starting in about 5 minutes. And as I said, my name is Ruby Campbell. I'm the Director of Advancement for SFU, Faculty of Science, Arts and Science, Social Sciences rather. There we go. Now I can see where I am. And what I was going to ask you to do is to please make sure that you get settled in. Please put yourself on mute, and please make sure that you can change your pronouns, your full name rather, and if you want to, please add your preferred pronouns. And please, if you want to, introduce yourselves in the chat box. Say hello, tell us where you're from, and we're just going to repeat this a few times as people enter in, because we have probably about 400 people registered, and we're letting people into the call as fast as we can. So I'm just checking the chat box. Let's say hi, everybody. And our panelists are on the call right now. And we are all just waiting until we can all let ourselves in. Again, I invite you to put yourself on mute, please, as much as we want to hear your dogs and your lovely children in the background. It might get a little distracting halfway through. And please put your name in there as well, if you don't mind, so we can ensure when we get out into breakout rooms, we know who you are. And to look at everyone saying hello. Oh, we have somebody from Edmonton. My goodness, I guess that's the beauty of doing this virtually. We have people from all over the place. Isn't that great? And I know we're going to have a lot of familiar faces, and I think you're going to have a lot of friends here that know each other. So for those of you that didn't know, today is National Seniors Day. That's what we recognize it locally, but it's also International Day for the Older Persons, and that's worldwide. So that is one of the reasons that we hosted it today on October 1st, is to honor that day and to have a conversation about our elders. So let's see, how are we doing for time? Oh, it's 5:30. Oh, right, 5:31 actually. So I think we're going to get started. I'm just going to look to Seth, though. Do we have more people in the waiting room, Seth? Maybe you can message me. Should we wait a little bit, or should we get started here?
I think we're good to go, Ruby.
We're good to go. Okay. Well, so just a reminder for those that are coming in, if you could please put yourself on mute. There is closed captioning available for today's event for all of the audio in the plenary. You can turn it on and off by clicking the CC button on the black bar at the bottom of your screen. So hopefully you can see that at the bottom of your screen. It should be on the right-hand side. And what we wanted to do is say, ensure that you have that if you need it. If you don't, if you're finding challenges, you can go to the chat and you can look for tech support and they can help you with that. But the closed captioning is available today. And many thanks to AI Media for partnering with us to provide this service. I also want to let you know that we are recording today's session and we won't be sharing it widely. It's primarily just so that we can have it for the, we'll be sharing the panelist sections, but we won't be sharing any of your questions or anything else. Okay, so I have the pleasure of introducing my colleague and wonderful friend, Jessie Williams. She is the Director of Indigenous Relations for the Faculty of Arts and Social Sciences at SFU. And she is, as I said, also a wonderful colleague, and she's here to start us in a good way. So please help me welcome Jessie.
Thank you so much for that warm welcome. Hot squile, Jessie Williams, Queens now. Good. My name is Jessie Williams. I'm a member of the Squamish Nation and of mixed European descent. I'm a mother and I'm a grandmother. And I'm here to continue the work of my elders who have taught me to be a connector. As I have been taught to do, I'm inviting each of you to step into your holistic intelligence, to connect your mind, your body, your emotions, and your spirit in this meaningful conversation. I invite you to resurface the teaching that guides you to do the meaningful work that you do. and remember what it was that inspired you to be a part of this virtual circle, this conversation. Today is a very special day. As Ruby shared, it is National Seniors Day. And as we gather to discuss how we uphold our elders, our seniors, and create an enhanced community of care, we must acknowledge how our society needs to discuss the harmful systemic gaps in our long-term care sector, lack of progress of policies and funding models that are vital to address issues facing our elders in care, and how this lack of progress has played a role in the staggering rate at which this global pandemic has affected our parents, our grandparents, and our great-grandparents. I reached out to some of my family and friends to ask how they have experienced what has happened during this pandemic to some of their elders who are in care. The most common response was around abandonment, and that abandonment can only continue if we allow it. Not intentional, but it still is. As I reflect upon my upbringing and speak with you today, I wear a scarf that belonged to my grandmother, my late grandmother, who spent her last years in care. I am reminded about the many teachings that she gave me on how we must all chen stway. We must uphold one another, especially for those who have cared for us, loved us, nurtured us, and shared their wisdom and teachings with us. Our elders carry knowledge of generations that is passed down along our family lineage. Our elders are the roots of our family trees. We are the branches, we are the leaves. We must protect our elders if they have protected us. Remember, we are all elders in training. I hold my hands up to each of you in respect for being here, for bringing the voice that is not in this virtual room with us today. The seniors and elders who need you, need us to advocate for their health and wellness, to inspire change, to be the change. We must revise our practices in care to make sure our most vulnerable are protected, and supporting our older people during the pandemic and beyond is everyone's business. Let's wake up our society and inspire action. I honor the opportunity to open this meaningful event. I respectfully welcome each of you who have come from many different backgrounds, walks of life, experiences, opinions, and understanding. Family, friends, colleagues, guests, welcome to the unceded Coast Salish territories of the Squamish, Tsleil-Waututh, Coquitlam, and Musqueam First Nations. May this knowledge sharing be heard with an open heart and an open mind. Thank you.
Thank you, Jessie, for your words. Always graceful and lovely, and elder in training. I will take that away. Thank you for that. So I have a bit of housekeeping that I'm going to do, and then I will get through that because I know we have an exciting program that all of you came here for. But I wanted to let you know that this event is hosted and produced in collaboration with SFU's Gerontology, the Department of Gerontology, Public Square, and the Advancement and Engagement for SFU's Faculty of Arts and Social Sciences. And we were really quite proud that we can bring this to you today. So you can find us on social media for all of those that are on Twitter or Instagram or Facebook underneath all of these handles. And please do share your learnings for today for those that couldn't be here. So again, if you didn't catch this earlier, we do have closed captioning for today's event, and you can see it you can activate it by clicking on the CC button on the black bar at the bottom of your screen. It should be on the right hand side. And many thanks to AI Media for partnering to provide us with that service. So before we get started, I want to discuss also our community guidelines. And this is just to make sure that today is a safer and welcoming and inclusive space for everybody. So above all, there will be zero tolerance for those who promote violence against others on the basis of race, ethnicity, national origin, sexual orientation, gender identity, religious affiliation, or different ability. Anyone who cites harm towards other participants in the Q&A will be removed at the discretion of our technical team and moderator. So please be mindful. Please don't assume pronouns, gender, knowledge based on someone's name or video image, please refer to people using their usernames that they provided. And this is a good reminder, if you haven't changed your username, if you'd like to, you just go to the top right hand corner, and there's 3 little dots in that, and that will let you change your name. And please practice self-care. If you need a break, or if you need to, get a glass of water, do whatever you need to do. And again, for those of you that are just tuning in, we are recording this session, but please be advised we will not be sharing anything from the breakout rooms, nor will we be sharing video of your faces or information in our post-video event. We will only be sharing the presentations of our special guests today with a wider audience. Our event structure is pretty simple. In just a moment, you'll be sent to a breakout room with a handful of other guests for a quick 10-minute chat to introduce yourself. You don't have to do a thing other than somebody will put you in a breakout room. So don't worry, you don't need to start to figure out how the technology works. We will have facilitators in each room who will identify themselves. These conversations are not recorded, and no one will be taking notes. They're just to have a moment where you can talk about real life situations and build a sense of connection in your community, because there's a lot of us on here, and it's important for you to meet a few people. So after your breakout rooms, we will reconvene. And again, you don't have to do anything. You'll be put back into the main conversation. And then I'll turn things over to our Dr. Habib Chowdhury, who's a chair and professor of SFU Department of Gerontology. And Habib will be our moderator for the main part of the program. And then once we get into the main part of the program, Habib will direct your questions to the panelists. So with that, I think we're going to go into the breakout rooms. We will have closed captioning still going on in the main plenary room. So if you'd like to have closed caption for the conversation, just leave your room and you'll come back to the main room, and that's where closed captioning will happen. So we're going to leave you for 10 minutes. Again, don't do anything. You will be put into a breakout room. So we'll see you shortly. Thank you. Hello, everybody. It's Ruby Campbell again. And you're all coming back from your breakout room. So as you return, we are going to make sure that all of you are able to hear us. We are going to get started with the program. What I do want to remind you is that there is closed captioning in the bottom of your screen. So you just need to click on closed captioning if you need that. And I also wanted to remind you to please turn off your sound. And you can also turn off your video. We encourage you to do that just during this time with the moderators. Please also feel free to write any questions in the chat. We do have somebody that's moderating that or that's capturing that. So if you have any questions, please go ahead and do that. So it's now my pleasure to introduce our moderator for tonight's conversation. It's going to be Dr. Habib Chowdhury. Habib is the chair and professor for SFU Department of Gerontology. He conducts research and consults work with various national and international organizations on physical environments for people with dementia in long-term care facilities, and memories of home and personhood in dementia, and community planning and urban design for active aging and dementia-friendly communities. We will post a link to his extensive bio in the chat, but without further ado, I'd like to pass things on to Dr. Habib Chowdhury.
Thank you so much, Ruby. That's a kind introduction. Thank you all for joining us today for this important conversation and important discussion. My understanding is that we have more than 400 of you joining us. As we have been saying for the last few months, we are in this together, and I'm glad that you are here to join us as being together in discussing an important topic. So I want to first thank SFU Public Square and SFU's Faculty of Arts and Social Sciences Advancement Office for organizing this timely event. And the Department of Gerontology is pleased to be a partner in this event. So at this point, I would like to ask you all to turn off your video so that we can give the spotlight to our guest speakers. So you can do that by clicking on the camera icon on the black bar at the bottom of your screen, and someone will be posting directions on how to do this in the chat box now if you need help. So I'm delighted to have an excellent panel of speakers who represent different stakeholders on this important topic of long-term care. And before I introduce the speakers to you and get started with the main section of the program, I would like to take a few minutes to share 3 observations on the topic. We know that there have been more than 9,000 COVID-19 related deaths in Canada in the last few months, and over 7,000 or 81% deaths have taken place in long-term care homes. Although our national response to the pandemic is considered as a success, the failure to protect our seniors, our elders in care homes, can be viewed as a national tragedy. The time for reform is now in long-term care, and we must seize this historic opportunity for meaningful reforms. So for all the different reasons we can think of for changes in how we deliver care and support in care homes, one major one is that we owe this to all the elders who have passed away in the care homes in the last few months and to their families. Second, there is a strong case to bring forward about bringing long-term care under the Canada Health Act. And there have been multiple discussions on that and enacting national standards for long-term care. So we are at a crossroads on reform on this front. One path would lead us to changes in staffing levels, increased protocol, increased wages for frontline staff, better infection control protocol, more funding for PPE, and many other areas. The other path is to include all of the above I mentioned and more, but those taking place as part of a transformative change, one in which there will be a systemic change in the organizational culture of care homes based on a vision of a holistic care approach, fundamental reform in staff roles and wage structures, and major investment in the physical infrastructures. In my view, we need to advocate for the latter option, which would fundamentally transform the current care homes to true homes where seniors won't dread to move in, places that will be a positive option to live in later life when we need care and support. And my final observation is that among the changes for care homes that would likely take place in the future, there will likely be a component for better preparedness against future waves of the pandemic. In this goal for safety, let us not sacrifice the importance of autonomy and dignity of our seniors who are living in care homes. In the past years, many care homes and health authorities have made important progress in creating person-centered and relational care environment. Let us make sure that those efforts are not sidelined in the planned changes to come. So it is now my great pleasure to welcome our speakers for tonight's event. Our speakers are Dan Levitt, Executive Director of Tabor Village. He's also an adjunct professor in the Department of Gerontology at SFU. Jennifer Lyle, Chief Executive Officer at Safe Care BC. Joy Parsons, Chief Executive Officer, Fairhaven Society. Lou Black, Director of Research and Policy for the Hospital Employees Union. And finally, last but not least, Isabel McKenzie, Seniors Advocate of BC. So we have an amazing panel here representing different sectors of the topic that we are about to discuss. So the following procedure will be followed moving forward. Each speaker will have 5 minutes to address the topic, and we'll have room for discussion before and after. Feel free to add your questions into the chat. We will have an audience Q&A session after the presentations, and we'll be logging all the questions we see before then. If you want to direct a question to a particular speaker, please put an @ before their name. So now allow me to pass the virtual floor to Dan Levitt. Dan Levitt is Executive Director of Tabor Village. And for detailed bios for Dan and others, please see the chat section. So I'm handing over this to Dan. Dan, the floor is yours.
Thank you. It's an honor to be here, especially on the International Day of Older Persons, the 30th anniversary of the UN Declaration. And I want to talk briefly in the next 4.5 minutes about the residents of aged care shouldn't surrender their human rights. And so I want to talk about the stigma that goes with the term resident. And it's really a narrative in aged care that we treat people who reside in aged care homes. We should treat them with the dignity and care that all human beings are entitled to. So just because they have a different address, a person living in an aged care home should not surrender any human right. They've simply chosen a different address to live in. During COVID-19, as we've seen the pandemic sweep through aged care, in every situation we must ask ourselves, what would anyone in the general community, irrespective of their address, expect? And I want to touch on 6 points. The first one is medical access. If a person in the community is unwell, they simply pick up the phone and get medical attention. So too, the person living in aged care must be able to self-initiate and access timely medical care. Secondly, the choice of where they live. If a person lives in a shared house and someone in that shared house tests positive for COVID-19, that person should be able to exercise available options and, if they choose to move out. So too, a person living in aged care must be able to have the same rights. Connection with family. Number 3, if a person lives in a shared house and someone in that shared house contracts COVID-19, the person will be able to communicate with people outside of their house. So too, all steps must be taken to ensure a person living in aged care always remains connected with their family. Number 4, access to acute care. If a person in the community is sick, they can call the ambulance or they can walk into the emergency department in their local hospital. A person living in aged care must be able to do the same. They have not given up any rights to be able to go to the emergency department when they entered aged care. Number 5, end of life treatment. If a person is offered treatment for COVID-19, their condition is individually and constantly assessed by medical professionals, and the options for treatment are thoroughly discussed. The same care must be available for persons living in aged care. They must not be targeted with advanced care planning strategies any more than anyone else of any age, or even their age. Their treatment should be not automatically assumed to be futile just because they live in aged care. And the 6th point, the voice of the family member. If a person nominates a substitute decision maker, usually the next of kin, to be contacted regularly with updates about their condition, it is expected to occur. So too, a person living in aged care should expect that their family members are involved in every aspect of their care. I believe strongly that older adults living in care have a life worth living, the optimal life that they can afford. And we cannot afford to do anything but that. I urge all of you to look at the older adults in your community, especially the ones who are living in aged care, to support the staff members. If you're a family member, to be supported by people around you, and for advocates, to do everything you can to comprehensively reject the stigma of a resident. In every interaction, the standard of care should be exceptional. The larger community standard is our compass. Do not accept that a life of a person in aged care is worth anything less. You are the voice of older persons. A resident of aged care is no different than anyone else. Thank you.
Thank you so much, Dan. Lots of helpful insights. I'd like to ask a question about how you have handled some of the pandemic-related challenges at Tabor Village in terms of staff teamwork, staff morale, and adjustment of how the care was provided. So can you share some experiences from that?
Yeah, it's been a huge challenge. During an outbreak, we had an outbreak at Valhaven. It's a 26 people live in that community, and we were on lockdown for about 10 weeks. And it had an incredible impact on the people who lived there. They were basically prisoners of their own bedrooms, a small space. The staff had to enforce that, and the pressure on everyone to wear PPE. The staff became essentially faceless people walking into a senior's room. Now they're gowned up. Families were not included in what was happening. And we had phenomenal staff, that they're healthcare heroes. We did everything we could to support them. We were quite blessed that a number of senior staff members, especially our director of care, basically ran into the fire, and they rolled up their sleeves, and they're incredibly healthcare heroes. So our worst nightmare came to fruition, that we had an outbreak. We did have one senior pass away. We had about a half a dozen people impacted. And then on our other community, a larger one, Tabor Home, we had we had a brief outbreak with one senior, and her family made the decision in her best interest, based on her choice, to move her out of the care home immediately to the local hospital. And she unfortunately died there within a week. However, that particular outbreak never happened. She moved out, and we were blessed that it didn't spread at all. So it's been a huge impact, and more in terms of the morale of staff, it's been really devastating for everyone from top leadership to the cooks, to the housekeepers, to the direct care staff, and they're all are just heroes. And the people who do the screening are amazing, and the family members have been very patient with the regulations around visitation, but it has basically it's been an upheaval for our industry, for what we do, and the kind of community that we expect to live in and work in is anything but what we expect. And I think the human rights of people who live there, and I would even say the workers, they're called into question because of those restrictions. So I could talk a lot more about this, but it's something that really we need to find a better solution going forward.
Mm-hmm. Really helpful insights. I'm also wondering, and there's a question about this as well, regarding family involvement during this time. And I'm wondering what your experience has been at Tabor, and you have further thoughts about moving forward. Are there better ways or more effective ways to keep the family engaged?
Yeah, I definitely think so. Just as in the same time that the Office of the Seniors Advocate in BC is taking the leadership role of doing a survey, we're doing it also. We're asking for feedback. How is our visitation program going? We're quite blessed in BC that a significant amount of money has been allocated to support visitation. So we're implementing that program. So we will be upping our game in terms of opening our doors. So there's two ways of having visitors right now. The essential visitors, which is really a family member who's part of the care plan, part of the personal care or even social care of the person who's living at a long-term care home. And I should clarify something that it was said in our breakout room. I think it was Barbara Lindsay from the Alzheimer's Society was mentioning this quite interestingly, that when we think about long-term care and we think about what we're doing now, the families are no longer part of that care. So if you really think about it, a once a week visit, it doesn't cut it, nor does a video conferencing. The essential visitors maybe, but before we had an open door, people would come and go all the time. And it was there were no such thing as visiting hours. There was no visitor restrictions, and we had volunteers. So the burden on staffs is monumental. So we have to do something much better for family members to engage them more and bring them back into the fold. I can't wait to be able to make that happen. We do have to balance that with the risk. I believe a recent outbreak that happened this week may have been as a result of a visitor coming in. So we have to make sure that we're not introducing further risk, but balancing that risk with isolation and loneliness, helplessness, and boredom. Some people will say that some seniors, some older adults in care, their comorbidities, certainly their outlook on life is drastically different than it was before because of COVID, because of isolation. So we all know how personally we would feel if we were stuck in a room without any contact with human beings other than caregivers. So we need to do a much better job at supporting visitors in our aged care organizations.
Thank you very much for those thoughtful and powerful comments and advice, recommendations, Dan. Thanks a lot. We're going to move on to our next speaker, who is Jennifer Lyle. Jennifer is the Chief Executive Officer at Safe Care BC. Safe Care BC has been instrumental in addressing the safety aspects of the pandemic situation in BC for the last few months. So Jennifer, over to you.
Thanks, Habib. And I want to take us all back to January. because in January, we were talking about a lot of things. We were talking about global warming. We were talking about Snowmageddon and the fact that the sky trains were having major issues and we were seeing major backlogs in stations. We were speculating whether Prince Harry and Meghan Markle were going to move to Vancouver Island. But the one thing that we were not talking about was long-term care, and we should have been. It's interesting because I've been reflecting over this last period. It's about just over a year ago, I was in Ottawa before the House Standing Committee on Health, and I used 3 terms to describe the long-term care sector. This was in the context of violence in long-term care, but those 3 terms were understaffed, under-resourced, and under pressure. And in a lot of ways, those exact 3 themes have come roaring back to the forefront when we talk about this pandemic. And then some new challenges. So when we talk about things like under-resourced, in our work, one of our major challenges that we had to tackle was the issue of PPE. It's interesting to reflect where we started because back in the beginning half of the year, the entirety of the long-term care sector was not integrated into the provincial pandemic PPE supply. And as early as late January, early February, there were some significant challenges that were coming to the forefront. We saw the collapse of the global supply chain. We saw entire nations engaged in bidding wars over PPE. And we saw the prioritization of the PPE needs of hospitals taking precedence over those of long-term care. What this meant is that by mid-February, 57% of the nonprofit and private long-term care and continuing care providers were already reporting challenges accessing PPE. That turned into 70%, nearly 70% reporting critical shortages of PPE in early April. And it wasn't until mid-April, mid to late April, that we saw the full incorporation of long-term care and assisted living into the provincial pandemic supply chain for PPE. And it wasn't until July that we saw the same integration of home care and community social services sector, both at the federal level and the provincial level. We need to do better. I think in many ways, BC was a leader in that we were some of the earlier adopters of integrating and bringing in aspects of long-term care and assisted living. But even at that point, as a safety association, we ended up taking the extraordinary step of setting up a public PPE drive to bring in 1.2 million donated items of PPE because there were so many organizations operating without a backstop. And we know the importance of PPE in infection prevention control now. The evidence is clear on that one. The other challenge that we saw, there's a lot of things that I could talk about in terms of under-resourcing, but if I'm going to pick 2, it's going to be outdated infrastructure and staffing shortages. When we talk about outdated infrastructure, it's important to remember that the average age of a care home in BC is over 30 years old. And not only is that challenging from a workplace safety perspective, from an infection prevention control perspective, it's challenging from a quality of life experience as well. Now, there are some good things happening. We saw earlier this week the announcement, and I believe it was the NDP platform announcement around investment in long-term care infrastructure. But it's unfortunate that it takes a pandemic for us to talk about these sorts of things because, again, thinking about what we were talking about in January, the discussion is very different today. I mentioned staffing shortages. One particular initiative, the single site staffing order, which is something that we supported very early on, about early March, while it was necessary to reduce infection prevention transmission risk, has also further exacerbated the existing staffing shortages we already saw in the sector. Now, again, we see some promising signs. We see the Health Career Access Program that's come to the forefront, but this is a longstanding issue that I know as a safety association, we've been drawing a link to since 2016. So it's something that's incumbent on us to address so that we can be better positioned to care for our seniors and our workforce going forward. And that brings me to my last one around being under pressure. In many ways, we have a hidden pandemic happening at the same time, and that's a mental health pandemic. We have continuing care workers who are reporting anxiety, who are reporting burnout. In a recent survey that we did over the summer, 76% of respondents reported feeling some level of anxiety around COVID-19. We hear anecdotally people reporting fear about being the one to bring COVID into a care home or being the one to bring it home to their loved ones. And we also know that about 10% of those people who responded to that survey indicated they don't plan on sticking around. They plan on leaving the sector. The primary reason cited was due to burnout. So again, here there are some promising practices. We have Care to Speak and Care for Caregivers, which are 2 mental health initiatives we're supporting with the Canadian Mental Health Association to address this, but this isn't something incumbent on all of us to bring to the forefront. When I think about overall how BC has fared, there are some good things. We've had, and I wouldn't say 156 deaths is ever a good thing. It's 156 too many. But in comparison to Ontario, BC has fared better, where over 1,816 seniors have lost their lives due to COVID-19. But we also need to remember that there were 335 healthcare workers who have been infected by this virus. And we know of one continuing care worker who has died directly because of an infection. So we can do better, we must do better. We owe it to our elders and we owe it to our future selves.
Thank you so much, Jen. I'm looking at some of the questions here. There's one question is, what is your assessment of our PPE situation today?
I think it's definitely better than where we were. And we saw that. So we've done about 4 snapshot surveys over the course of the pandemic. Our most recent one was back on August 11th. And we saw that the numbers had dropped significantly in terms of the percentage of providers reporting critical shortages. So we saw the number go from a high of about 69% down to 17%. Now, I certainly don't want to normalize that. Under normal circumstances, it would be extraordinary that anybody would be looking at that sort of tenuous supply. But it is a positive development. And I do want to give credit where credit is due. I mean, we've seen some pretty significant investments in terms of creating domestic supply chains of PPE. And we have seen ultimately the expansion of federal and provincial efforts to incorporate the entirety of the community and social support services sector into that. So I think we're certainly in a better position than we were back in April. But I also want us to think that this isn't just an issue we're going to see with PPE. At the heart of it, this is an issue of resource scarcity and how you triage. And in a lot of ways, we will likely run into a similar situation when we talk about a COVID-19 vaccine. So I think it's really important that we learn from our earlier experiences and make sure that we are prepared to address those issues of resource scarcity when they come up again, because they will come up again. They'll just have a different face to them.
Thank you, Jen. There's a clarification question. Where were those shortages reported? The 17% of care homes. You're on mute, Jen.
Sorry, it was 17% of providers. So in those surveys, we surveyed the independent living, assisted living, long-term care, community living, and home care sectors. And so the percentages varied. The sectors that fared the best were long-term care and assisted living in that August survey. And all these survey results are public. We posted them all. The sector that fared the worst was home care. It was at 36%, reporting 3 days or less of PPE, which is how we define critical shortage. Okay. And we're not the only ones who've spoken to this. I know that there's been, our union counterparts have been discussing the challenges that we've seen with regards to PPE. We have heard care providers come out and publicly talk about it. So again, while we're in a better position where we were, we know that this race isn't done. So we need to make sure that we're well positioned to address any of the challenges that come down the pipeline.
Okay, so one more question for you in this round. It's a question about home care companions. So the question goes, it would be great to be able to, or comment or question, it would be great to get the home care companions and caregivers back into the LTC homes and back to the previous clients, thus lightening the load for some of the house staff. So you have any thoughts about that?
Yeah, I echo Dan's comments earlier, and I have a very personal family experience with the challenges and the heartbreak that comes with this. There is a way forward. We know that there's a way forward where we can find a balance between having family members and having personal support workers coming back into care homes. And in some ways there are ways for that to happen now. We have essential visitors, we have the social visitation policy, but there is a way to do it safely and to do it more. And I know when we partnered with Family Caregivers of BC to develop infection prevention control training for family members so they could come into long-term care and assisted living residences with that full knowledge that they needed to be safe. We were very much committed to this idea that family members have an important role to play. And it's not just for the benefit of the resident or the elder in care, but also too for the staff themselves, because It's morally distressing for staff to see elders in their care cut off from their social networks and the people that they love. And quite frankly, it's an increase in workload because of the valuable support those family members and external caregivers provide.
Thank you, Jen. Thank you for the powerful presentation with lots of interesting and helpful insights. And thank you for leading Safe Care BC so effectively and continuing to do so. So we're going to move forward with our next speaker now. And our next speaker is Lou Black. Lou is the Director of Research and Policy for the Hospital Employees Union. So Lou, the floor is yours. Please go ahead.
Thank you, and happy to join everyone on National Seniors Day. HEU, the union that I work for, represents about 50,000 members, and approximately 1/3 of those are care aides. The vast majority of those care aides work in long-term care. And I think, as other speakers have already alluded to, COVID has essentially put a magnifying glass to the problems and issues that already exist in long-term care. So chronic understaffing, wage disparity and working conditions, that one hasn't been mentioned yet, but those things make it much harder to attract and retain workers, and a lack of accountability in ensuring that money goes to direct care. I would say that that one hasn't been discussed yet either. I want to talk for a minute about the single site orders. I think lots of people tonight will already be familiar with them, but not everyone. They were established back in June, I believe, by the provincial health officer. It's when they were finalized. And what they did was restricted workers to working at just one site if they worked in long-term care, assisted living, or provincial mental health facilities to help prevent the spread of COVID and to ensure that there was enough staff at all sites. And implementation in our province went far better than other provinces. And we can attribute this to the great collaboration that happened between employers, unions, and the Ministry of Health. Government taking a fair approach to workers' wages and making sure that all workers in long-term care were leveled up to the same wage. If they were going to be forced to stick with one employer, then that was important that there not be that inequity. So it's been an excellent example of what's possible in a short period of time with cooperation and a supportive government. The necessity of these orders have made some underlying problems with the system clear, including the lack of continuity. So the fact that many care aides have to hold more than one job because there's insufficient hours or wages to hold just one job was brought to light during COVID. And these standardized wages that have come with the single site orders have been needed for a long time. It's something that we're pretty close to having back in 2001, but the previous government slowly eroded that with their legislative and policy directions. I just want to share a few of the impacts of COVID-related policies. And again, some of them have already been mentioned. The lack of surge capacity meant that when some staff were unable to come to work due to COVID, and in combination with other leaves of absence and vacancies, short staffing was routine. This single site order exacerbated that because there's no casuals available to cover leaves, the regular leaves that staff are entitled to. Remaining staff are often left to work overtime. I've definitely spoke with members that work 7 consecutive overtime days and had to have their vacations canceled and are stretched extra thin to meet seniors' care needs. The impact of short staffing, I think Jennifer spoke to this as well, became more apparent when family members and volunteers who provide a significant portion of physical and psychosocial care were not allowed to visit long-term care. So care aides increasingly spent their time helping residents to FaceTime, we know the stories, and to help their families connect using other means, struggling to try to provide the additional aspects of care that the residents so desperately needed. Then when the essential visitors policy came to be, of course, we're very happy that seniors can see their loved ones again. But their workload volume has intensified again due to the increased work of overseeing safe visits. So in speaking with our members more recently in some focus groups, we found that the care aides are expressing that they're often pulled from their regular work tasks to take residents to meet family members for a visit without prior warning. This isn't happening at all sites. Some sites have a very coordinated program. I've been happy to hear about those, but still there are a number that are not functioning that smoothly at this point. And so in those situations, care aides are pulled away from their regular tasks. It means additional time for our members who are already working against the clock to try to meet folks' needs. Some of the visitors coming in are struggling with the COVID protocols and continue to act as though it's pre-pandemic days, wandering into neighboring residents' room to chat. And there's no assistance or supervision for this situation, yet there's a clear need to be able to support the visitors themselves in this process. In some facilities, there's no staff to coordinate visits on weekends, yet family members show up unannounced sometimes on the weekend. And family members generally are struggling to understand why they can't visit more frequently, quite understandably. And care aides feel that they're bearing the brunt of that frustration. So I'll just close off saying our members are struggling to provide optimal care at the best of times, given the insufficient staffing in most care homes. And they're forced to make the difficult choice between forgoing basic care like baths and getting residents out of bed and dressed for the day and prioritizing other essential tasks. The pandemic has made the situation worse, and we've heard many stories, as Jennifer was speaking about as well, of members' moral distress and burnout and the emotional impact on mental health. So things that we're clear that we need, and this is by no means an exhaustive list, we know that we need a lot more staff, and higher staffing levels must be made mandatory and enforced. We know that the wage equalization that came with the single site orders has to be continued if we're going to stabilize the long-term care force and be able to attract and retain people. We know that a greater portion of the money spent in nonprofit sector of long-term care is realized in actual care hours for our seniors, as a seniors advocate study just last year pointed out. And so we need greater accountability from the for-profits, and we need any new investments to go to the nonprofit sector of long-term care. The announcement, again, Jennifer referred to in the NDP, that was part of the NDP's platform. That's the first investment we've seen of that size going into long-term care infrastructure and into public infrastructure in decades. It's most welcomed. It's thoughts on what needs to happen at a national level as well, but I'll save that for later conversation. Thank you.
Thank you so much, Lou. I'm looking at some of the questions coming in. Here's one for you. Do you think there would still be staffing crisis shortage in long-term care if all care aides had permanent full-time positions?
It's an aspect of the issue, absolutely. Even within the health authority owned and operated sites, it's just under 50% of care aides that have full-time jobs. And this situation is exacerbated in private facilities. So it is an aspect, the hours of work, but also the conditions in terms of pay and benefits themselves. There's as much as a $7 an hour gap in pay without that wage equalization that's happened under single site orders. We have to remedy that. We have to make sure that that gets carried into the future and past the pandemic. That's what's going to attract workers and keep them there, in addition to improving the short staffing.
Mm-hmm. So I think this is a related question about this quote unquote pandemic pay. What is your assessment around the pandemic pay for frontline essential healthcare workers? Is this something that will be implemented moving forward?
We sure hope so. The Hospital Employees Union is advocating for it. We think it's essential. I think it's impossible now that people have experienced this to tell them no and to say that we're going to go back to the way things were. And it should never go back to that. We call them heroes. You know, we did the 7 o'clock cheer for many months, and we need to make sure that we back that up with actual investment.
Well, more questions coming. Here's another one. Is it true that for-profits get adequate funding to compensate healthcare aides at the same level as the highest paid, but they don't receive the full wage?
Sorry, can you repeat that?
So is it true that for-profit providers get adequate funding to compensate healthcare care aides at the same level as the highest paid, but they don't
Yes,
receive the full wage?
that's correct. So they do get funded with the same funding scheme. There's a little bit of variation among health authorities as to how they do it, but they do get the same funding. It's always based on an average, and the seniors advocate would be able to address this as well, as she knows it intimately, given her recent study. So they are funded to pay that wage, and they choose to pay a lower wage.
Mm-hmm. So here's another question, Lou. I'm wondering if you have any thoughts about the fact that most of the frontline workers belong to immigrant, racialized members of the community, and in terms of their voice being heard in a stronger way. So are there extra measures being taken or voices being given to the frontline workers in that sense, given their backgrounds?
We've, in recent efforts between our union and the employers, the Health Employers Association of BC, we've been working on recruitment and retention efforts. There is big emphasis there in making sure that there is greater representation and opportunities and promotion to Black, Indigenous, and people of color workers within the sector. That is happening, trying to make sure that there are better conditions of work and opportunities for promotion there. Within our union, that's certainly true. We have many activists, particularly, they do tend to show up more in the contracted support service sector, so we're more privatized sectors. We see that and certainly fight to try to remedy situation.
Okay, thank you so much. Lots of questions coming, but we'll wait for the final round and come back to you and others. So moving forward with our next speaker is Joy Parsons. Joy is the Chief Executive Officer of Fairhaven Society. And again, all of our speakers' bios are coming as they appear on screen. So Joy, the floor is yours. Please go ahead.
Joy, you're muted there. We'll just get you to unmute yourself.
You would think I'd be better at this tech stuff by now, right? 4 months or 5 months of Zooming and I still haven't got it figured out. But what I was saying to myself and no one else is how exciting this discussion is, because I'm in agreement with so many pieces that are coming forward, and I'm so appreciative that everyone's here sharing their expertise. As Habib mentioned, I'm the CEO of Fairhaven Home Society. We are a charitable nonprofit organization. We provide homes and care to more than 600 seniors in Burnaby and Vancouver. All of our staff are unionized staff, and we have fabulous retention statistics with our staff. I'm also the chair of the Vancouver Coastal Administrators Council, so a number of my colleagues and I get together on a regular basis and talk about our challenges. But today I just want to speak about my own experience. So I'm not wearing the hat of the Vancouver Coastal Administrators Group or the Fraser Health Group. I just want to speak about my own experiences through COVID. We have 2 long-term care facilities and 3 independent living facilities, all totaled, as I mentioned, 600 seniors that are supported through Fairhaven. We have more than 400 staff that are also supported through Fairhaven and the services that we provide. When I look back, Jen said, what were we talking about in January and February and what happened in March? I have no recollection of March or April. It was chaos. It's all a blur to me. When I think about the challenges that we faced, it's really hard because there was so much going on. And so when I think about those challenges, I just want to say chaos. So there was chaos because there was anxiety. There was anxiety with my staff. There was anxiety with the families. We had so many uncertainties going on, so many questions. One of the biggest challenges that we faced was trying to weed through all of the information coming at us. So many of our partners in the system and care were trying to be helpful and provide us the latest information, but it got overwhelming. Daily, I would receive more than 30, 35 emails on the latest equipment to use or the greatest suggested infection control practices. So part of my challenge was really trying to navigate all of the information coming out. And again, I applaud everyone's intention to be helpful, but it was very, very difficult for us. And what I was trying to gather was, what information can I take to my team to answer questions and to reduce the anxiety? Because my team, we took the approach of, we are going to tackle this head on. We're not going to be afraid. We're not going to hide. We're going to embrace ourselves. We're going to be educated. We're going to provide as much information as we can to our staff, to our families, to our residents, to all of our partners. And it was just really hard to filter through on what is the information. And understandably, unprecedented. And you know, I was tired of that phrase, but the reality is everything we were going through was unprecedented. So the information did change daily, and new learnings happened daily, and new understandings happened daily. But for us, we really value our staff. Right at the beginning, our board was dedicated to making sure that our staff had what they needed to feel comfortable in their job, have the tools that they needed to do the work that they were doing. We're not fearful of losing their positions or challenges. But admittedly, early on, and I'll sidebar by saying, thankfully, we have not experienced an outbreak at any of my 5 buildings. Thank you. But our staff were afraid. And, you know, we talked about staffing shortages that were present prior to COVID. We lost some staff just out of fear right in the beginning. Like, people just went into hiding and didn't want to work. And as I say, our board really supported that we support these staff members to, you know, feel safe and do what we can to ensure that they're not worried they're losing their work, or that, you know, they still have a home in the Fairhaven family. And when we can get them back into a place where they're comfortable working, we'll do that. But that was a lot of the work that we had to do early on. You know, our leadership team, God bless them, they're fabulous. I'm sure they all will say they don't remember March and April either. Everybody worked 18, 19, 20-hour days, just trying to be there for everybody. Our staff, as Lou mentioned, those staff that remained with us, we were short-staffed already. It got shorter. How did that time happen so fast? Short staff already, and then COVID happened, and our staff are working more than is humanly acceptable, but they're there because they are dedicated to our residents. It's our staff who were so dedicated to making sure that we're keeping our residents safe and keeping our staff safe. Our challenges with PPE, they were coming up with solutions. You know, we had everybody on the internet. How can we make PPE? How can we get PPE? How can we reuse PPE safely and effectively? And I really applaud all of our staff for doing that. So, you know, my hopes going forward, our healthcare heroes, they're labeled as essential workers, but I don't think historically we've treated them that way. These staff are critical. And, you know, we talk about making sure people have good wages. All of my employees are union employees following the Master Collective Agreement. They have good wages, they have good benefits, but living in this community of Greater Vancouver and the Lower Mainland, it is not a living wage for them. So they are working multiple jobs because of our environment. So, you know, and the majority of our staff are full-time positions. So somebody asked about that. Almost all of our staff are full-time positions, but I still have challenges on an ongoing basis. So, you know, I could talk forever. For me, it's been a crazy learning experience. Our staff are the foundation of making sure that we're doing the best that we can. They are dedicated to our seniors. They are dedicated to the families It's our staff who created solutions on how to get families back in and visit them. It's our staff who are really helping families, teach them the infection control because they know how important the families are. Kudos, Jen, thank you so much for the family education online. We almost require our families to participate in that education before they come back, but it really is helpful. We're trying to stay connected, communicate, keep everybody informed, all of those things. So yeah, we've learned a lot through this pandemic, and we continue to learn on a daily basis. Life continues to change and we're learning new things. I just hope that lots of good things come out of this in the future.
Thank you, Joy. Lots of interesting insights and experiences from Fairhaven. I'm looking at some of the questions and comments here. Let me share with you one comment here and get your response. Why do staff have to work 14 to 20-hour day days? The staffing has been so curtailed by provincial financing that there isn't any cushion for difficult times. So do you have any thoughts?
That's a really interesting question and a conundrum that we have. So we currently, the funding model is almost directly related to tasks that happen in a day and hours of resident care that are provided. And for us to be funded appropriately, we have to maintain a certain number of hours of resident day or hours of resident care that we provide every day. If we don't achieve that, the funding gets clawed back. So we lose that funding if we haven't hit those hours per resident day. My organization, and I won't speak for myself, we try very hard to not allow people to work a 14 to 20-hour day. So we've worked collaboratively with our staff to come up with creative solutions to how and to fairly and equitably move overtime shifts so that people aren't doing that. It's not good for staff. It's not good for the staff's families. It creates exhaustion and fatigue, and that leads to questions in quality of care and mistakes. Sadly, though, we do have to meet requirements of care for us to maintain our funding, and our margins of funding are very limited. So to the thought of care dollars being clawed back because we haven't achieved those hours is difficult. But, yeah. I don't know if that answered it, but for me, that's a challenge. We try really hard not to have any staff work double shifts ever.
Mm-hmm. Thank you. There are a few questions about staff mental health support. So about bringing in counselors and giving more effort and support on that front, which is a critical front that has been mentioned by other speakers as well. So your thoughts on that, Joy? So
I agree. As I mentioned, some of the biggest challenges we had in the beginning were the staff anxieties. Fairhaven, we have an employee family assistance program that we provide, and we make sure on a regular basis staff are aware how to access that individually. We also use our daily safety huddles to talk about different topics, and one of those topics is self-care and how to manage self-care and how to access services if you're needing help. I'd like to believe that our organization has very open door policy and people feel comfortable walking into my office and asking for help or raising a challenge or highlighting a need. And I know very deliberately that my direct care managers are engaged daily in conversations with staff on how we take care of ourselves. We do have done numerous amounts of staff appreciation sessions over COVID. Just last week, we brought in boxed lunches for everybody. Thank you to BC Care Providers and Safe Care BC. They've accessed a lot of donated materials. We had beautiful chocolates that we had for staff on a regular basis. We had a number of like hand sanitizers for staff to use and take home. We purchased materials for staff to take home for their families so that they can feel safe there. But it's that family approach to making sure staff know that they are cared for and they are supported. Because the anxiety is high. And I can say for me, our staff, the average age of my staff is over 47 years old. So these staff are sandwich generation. They're caring for their own elders. They may have kids at home. There's lots of challenges, and we just do whatever we can to support them.
One last question for you before we move on. I think you mentioned about education for families And there's one question about if you can elaborate on the education referred to for families.
Oh, so I should put that back to Jen, but Safe Care BC worked in partnership with, I'm going to get the name wrong, it's gone for me, a family support group that works for families who are providing support for families giving care, and have created online education sessions on how to enact infection control and safety procedures. It's accessible to everyone online, and I think actually Jen should answer that because she knows more about it than I do.
Yeah, thanks, Joy. So it's in partnership with Family Caregivers of BC, and basically, it just came out of the fact that when we were understanding what the issues were, there's a real fear, and arguably it's a valid one, of family members inadvertently introducing COVID into a care home. And we know that this is coming at a time when sites are incredibly strapped for staffing resources. I mean, Lou spoke quite eloquently to the challenges that people face around facilitating safe family interactions. So this was kind of our way of making things just a little bit easier. It doesn't replace the site-specific orientation that needs to happen, but it helps ensure that people walking in the door already have a baseline understanding what they need to do, so that you're not having to explain to somebody, yes, you need to wear a mask. Yes, you need to wash your hands for 20 seconds. Yes, you should keep your bubble small if you're supporting someone in long-term care. So that's what this was intended on doing. And it's free. So it is free, it's publicly available. And that's how we wanted to help support that safe reintegration of family members back into care homes, because we know this is something we're going to be dealing with for months. And the emergency measures we put in place into March aren't sustainable in the long term.
Okay. Thank you, Jen, for that answer. And thank you, Joy, for the presentation and taking those questions. We're going to move ahead with our final speaker. We're very pleased to have Isabel McKenzie, who's a senior advocate for BC, who would share some reflections and perhaps some survey findings. So, Isabel, the floor is yours. Please go ahead.
Well, thank you. And thank you to all the previous speakers. Many of, I think all of you I know, and some I feel are colleagues, those of us, Joy and Dan, and those of us who've actually run care homes, we know what the challenges are and how difficult a time this has been for everybody. And I think that to sort of end on a more uplifting or hopeful note, although this is called a crisis in long-term care, but I think that one of the reflections that I have is that when the CF went into those care homes in Ontario and we sent in these strapping, young, healthy, fit people into care homes, and they came out and said, this is just horrible what we're seeing, and they described what they were seeing. And I think those of us who've worked in long-term care for Joy and Dan and myself over 25 years probably said, well, what did you think you were going to find? That is life in long-term care, that people have to wait, that it's not as individual as we would like it to be, and that there's a difference between what some people think is going on and what's going on. And one of the things that has happened in this is we need to remember most people in Canada and in British Columbia are never touched by long-term care. They don't know anybody in long-term care. They're never going to be in long-term care. You know, we only have, what is it, about 33,000 people in long-term care at any one time out of a population of 5 million people. So when you do all the math, you realize that part of the challenge of getting the changes and the will that we need to get the changes that we need is to get people to care. And one of the positives that's come out of all of this is that when this was revealed, the public met this revelation with outrage, and that it wasn't acceptable, and that they do care. And I think that that is critical, because if we can get the public at large, it's their system, and if we can get them to support it, then all of the changes that we want will follow, because at the end of the day, if the people really want it, then it is going to happen. Because I think the other reality that is dawning on certainly, I think, the decision makers is there's no solution that doesn't cost more money. And yes, some of it is reallocating money, and some of it is, as some of the speakers have spoken to, ensuring that public dollars are being spent in the way that is supporting the public interest in long-term care. That's true. Some situations are more about reallocating money that's already out there, but there's no universe in which there isn't going to be more money needed. And when my office undertakes all the reviews and we see all of the various data from all of the care homes, publicly funded care homes in the province, you're struck by, first of all, the diversity, that some are struggling, others aren't, frankly, and that you're going to have to help those who are struggling to be able to make sure that they can provide an environment where our seniors who live in long-term care get the care and comfort and affection that they need. And we know that that is going to come. There's a component in long-term care that is about clinical care and is about nursing care, but 70% of it is about our care staff, our care aides. That's who, when we think about what matters to the people who live in long-term care, Joy and Dan, we fuss around in the background a lot, maybe more Joy and myself than Dan. We look at all these indicators, we chart things, what are the falls, what's the weight, we look at, what's the medication reconciliation, we look at all of that. But if we step back and said, on a day-to-day basis of the person who's living in this care home, who has come here for effectively the last 2 years or so of their life, what matters to them are those daily conversations that they're going to have. Are they going to be able to have their lunch? Is somebody going to be able to help them? When they go into a room, is there somebody that's going to be able to help them to participate? Those are the things that are really about bringing meaning to the life of the person in long-term care. A large piece of that is about our staffing. And I think a large piece of a number of staffing challenges that we face as we not just equalize the wages, that's only part of it. It's then what those wages are and who we're going to attract to be a care aide as a profession. We will see over time that some of the issues we're facing around shortages in recruitment, et cetera, will be remedied to some extent by showing how valuable this job is. And part of it, a big part of it, is in the hourly wage. But then there have to be enough hours at that hourly wage, because all of us live in a world where it's how much money do we make each year, not how much money do we make each hour. And so we're going to have to address that in how we staff our long-term care homes. And it's a very technical issue, and I appreciate that a number of people participating in this webinar may find it a bit mundane to talk about, but it's very important that we've got to find a way to create the full-time work, and that may require us to rethink who does what in long-term care. We've fragmented healthcare to a significant extent over the last 25 years, and that's no different than what we've done in long-term care, and part of that has been born out of practices we started 20-some years ago, where we said, well, I'm going to contract somebody to do the food part, and I'm going to contract somebody to do the cleaning part, and I'm going to contract somebody to do the care part. And so once you started down that road, the ability to say one person could do all three of those things and have a full-time job was gone. So we're going to have to think about that, and that's going to be a challenge to all of us, because we have tended, we do it in other parts of healthcare as well, in home and community care, where we have fragmented a lot of work that used to be done by we called it the district nurse in the old days, or the case manager, we've now segmented that and specialized that a lot. And we had good reason for doing it at the time, and we thought it made sense at the time, and there are some benefits to it, actually. But there are some unintended consequences. And I think that has revealed itself during this pandemic. So I think we're going to have to look at how we staff, not just with the proper wages and benefits, but also how we're going to create these meaningful full-time jobs, because that's going to allow the connection with the residents. It's going to be the people that are there on a daily basis for several hours a day that are going to form those relationships with the residents. And that's what they're going to really value. So I think that's a big piece of what we have to look at. And I think another piece that we have to look at is the model we started on, again, about 25 years ago, where we went to complex care. I was part of the group. I mean, we looked at it and we said, well, we don't want people to move. And so when they go into care, we're going to have one category called complex care, and you're never going to have to move to extended care if you come in at intermediate care. And that was it made a lot of sense at the time. We didn't have a lot of good data back in those days. And if we had, we probably would have seen that the trajectory isn't quite what we thought it was, and that most people probably wouldn't move, and that the unintended consequence of creating complex care as the category of licensed care is we've thrown a lot of people together who have very different, when you look at the spectrum of care needs in a particular care home, you see a wide variety. And so you have to ask yourself, how are we meaningfully and effectively providing programming and social stimulation and the rest of it to this wide variety of people? Because if you're meeting the needs of this group of people, you're not meeting the needs of this group of people. And we certainly found that when we surveyed all of our residents and family members back, I think it was 3 or 4 years ago, and we asked a lot of questions, some of them on this meaningful engagement. And what we found was about half the people said, there's nobody here I have anything in common with, and there's nobody here I really can talk to about what matters to me, and nobody really asks my opinion about anything. Now, half felt more positive about it. I mean, that's always the challenge, that in any care home out there, you're going to find people who think it's pretty good, and you're going to find people who think it's pretty bad, and yet it's the same care home. And part of that is obviously different expectations, but also a big part of it is maybe it does work well for this group of people, but it doesn't work well for this group of people. And we've put them all together. And so how are we going to look at that going forward? You know, we often talk about this Devalued dementia village in the Netherlands, and it's the, you know, it was the greatest thing since, there's always a greatest thing since popcorn at some point in time. And so we all decided it was about creating the village, and it's all about, you know, they can cycle to the chocolate shop and they can go and get a beer when they want, important elements. But one of the big elements that makes it successful is that they group people together by interest. And they only group 6 of them together, by the way, and we've morphed that quite a bit. I was involved in the first dementia house in British Columbia, and we stretched it to 15. And then I could see what was coming down the road pretty quickly was that we were going to rationalize how it should be. The optimal number should be 25. And every optimization that we rationalized was based on a staffing model. And it was based on the efficiency of the staffing model and the ratio of the staffing model. It wasn't based on what residents really wanted. We don't live with 24 other people in our life on a normal basis. Families are smaller than that. But that fit our staffing needs and our staffing ratio. And so, you know, we really have to think about, okay, if we're serious about this, we're serious about it. And we need to be honest with the public, with the residents, with the staff, and with the family members when the fiscal realities are conflicting with what is perhaps optimal. And there will be times when we will choose what is more fiscally prudent, for want of a better term. And we should be honest about that instead of trying to rationalize it some other way, because that frustrates people. They see through that. And that's a big part of what makes them feel not valued. Because, whoops, hang on, can you hear me?
Yes.
Hang on, my tower fell over. Can somebody give me a thumbs up if they can hear me?
We can hear you.
Thank you. My computer just fell over on the floor. I kicked it by accident. So, you know, people, part of what is going to make people feel less valued is when they feel they aren't heard. And when they're trying to tell us things aren't great, and we're trying to parrot back to them why it is great, they feel not valued because they're not being listened to, rather than acknowledging, you know what, it's not great. And we know it's not great, and we're sorry it's not great, and we're going to try to fix it. But these are the things we have to do in order to fix it. And I think if we, you know, getting back to the very beginning of my reflections, which is if there is a strong public will and or public demand for the changes that need to happen, there will be the ability to make those changes happen. And I think that what we all have to do now is ensure that this groundswell of public support for seniors and outpouring that we've seen over the course of this pandemic is sustained once we're through the pandemic. All these, COVID didn't cause all the issues that Joy has talked about in her care home and Dan has talked about in his. COVID didn't cause those. They were there before. COVID revealed them. COVID potentially exacerbated some of them. But we had these issues before. And the fix to them, some of the fixes are going to be difficult to meaningfully do until we're on the other side of this pandemic. But we can start on our road toward that. So I think in the interest of time, I'll probably stop there and turn it back to you, Happy, to see if there's any questions.
Mm-hmm. Thank you very much, Isabel, for...
I can't hear you.
Can you hear me now?
Okay, I've lost the ability to hear. Just a minute.
Okay.
Because my headset has been disconnected here. Hang on.
Can you hear me now?
No, I can't hear you.
Okay, so maybe you need to check your settings, the audio settings on the Zoom, and then hopefully.
Okay, I cannot hear.
Habib, maybe we can give Isabel a little bit of time to reconnect, and maybe you can, if we have time for questions, sorry, it's Ruby, we can take some of those other questions in the meantime.
Right, we're going to go ahead with a few questions here. The remaining time, 7 to 10 minutes left. There's a lot of questions here coming, excellent questions. So we'll try to go through some of these as best as we can. And some of these are open-ended with the whole panel. Some are targeted to specific individuals. So here's a question so I would ask all the speakers to to unmute themselves so we can quickly get to them. So this is a question for Lou. Could you share a couple of thoughts on why you feel more investment should be directed to nonprofits rather than for-profits?
It's pretty simple. There's no profit motive when you're dealing with the not-for-profits. And so the money that is spent on staffing, which is the bulk of the cost of operating a long-term care facility, goes directly to the care that our seniors benefit from and that we want them to have, that informs their quality of life in that final time. So the Seniors Advocates Office produced a study I'm trying to recall if it was earlier this year or at the end of last year. It's called A Billion Reasons to Care. And as I said earlier, she knows it intimately. She could give these stats much better than I could. But she found that nonprofits under-delivered in the total number of hours that they were funded for, whereas not-for-profits over-delivered, I think to the tune of something like 80,000 hours. They over-delivered. So they did extra fundraising, et cetera, to try to get more staffing hours for their facilities. And we saw the opposite with not-for-profits. So it's pretty clear.
Okay, thank you, Lou. Here's a question for, I guess this question maybe Dan or Joy can respond to. Are there any restrictions on donations of food or staff appreciation from the community or unions?
It's Dan. I'm happy to answer the question. No, there's no restrictions. We would love your generosity. There are some kind of silly things with COVID that we have to kind of make sure that COVID's not brought in by that package. But otherwise, we would love to have any kind of donations that you're interested in making. So we are charitable, and we would love any help you're willing to provide.
I will echo Dan. Yeah, we would love donations. But because of COVID, we have stopped sharing food. So families used to love to buy pizza for the staff in the evening, and that's not really appropriate. So we've been receiving donations of like single boxed lunches or boxed meals. That's lovely. Prepackaged chocolates. Everybody loves chocolate, especially me. So yeah, those types of things are fabulous, and the donations really do help us in so many ways.
So here's a question, again, maybe one of you can answer. Can casual staff access the EFFP programs that we have touched on?
Yeah. Yes. Our organization makes that absolutely accessible to all of our casual staff as well as regulars. I think that is an individual organization's mandate to determine how they use that, but speaking for Fairhaven, yes, our casual staff are accessible to EFAP.
Yeah, and same thing with Tabor. Sometimes the casual staff and the permanent staff, because of status, there's a hierarchy, and we try to eliminate any of that potential conflict. So part of it is making sure they have as many of the same benefits as possible. And the Employee Family Assistance Program, along with other provincial supports that Safe Care BC supports and others, are certainly available for casual staff.
Okay. Here's a question that maybe Lou or any of you can answer, I think. We're hearing that LTC staff are working at one site, but also have jobs outside the facilities in different lines of work. How is this safe for our seniors, yet families that have very small bubbles are not allowed essential family status?
Habib, I can jump in on that one just to clarify, because I know that sometimes there's a bit of confusion around the single site staffing order. So the single site staffing order speaks specifically to licensed mental health facilities, assisted living, and long-term care. So effectively what the idea behind it is that you can work at one long-term care home, but you can't work at two, or you can't work in long-term care and then work at an assisted living residence, for example. There are no other prohibitions around that. So if a staff member was employed, for example, as a personal support worker in somebody's home, and then also working in long-term care, then that is technically allowed under the single site staffing order. And I can't necessarily speak to the rationale behind that from a provincial health officer perspective, but I do know that that's essentially the text of the order as it stands, and I understand how that can sometimes bring confusion.
Okay, thank you for answering that, Jen. Here's a question for Joy. For the number of hours that resident client care has to be provided, does this data or information have to be reported to the government in order to maintain adequate funding?
So absolutely, we do very detailed reporting that goes directly to the health authorities. My assumption is that it goes back to the government as well. And most recently, the government has implemented a new standardized tool that all reporting will come in directly to the government. Until now, each health authority collects their own information slightly differently. So for organizations like mine that bridge multiple health authorities, it's a little bit onerous in that we were providing different information to the health authorities, but absolutely. Very detailed information about the staffing hours, the pay, the worked hours, the relief hours, the overtime hours. It goes on a regular basis to the ministry now directly from all care providers. Well, from all contracted care providers. I'm not sure if the owned and operated facilities also submit the same information that we do, but I do know that contracted care providers like myself, yes, we do regular reporting to the ministry.
Thank you, Joy. This is the next question is a big one, yeah, any of you can answer. Obviously, the question is about assessment and about metrics that are used for assessment of quality of life issues, but mostly we're talking about just quantifiable. What other metrics beyond quantifiable can be used to measure and enhance quality of life for residents?
Well, we can talk about asking the residents what their quality of life is like. So if we look at the survey, for example, that we did, I think it was about 3 years ago, there were a lot of questions that are not quantified in terms of money and where money is being spent or clinical indicators, but really about how the person thinks about a lot of the aspects of living in that care home. And so I think that we can look to that and be guided by that as well.
And I'll just add to that, Isabel, I agree. Our organization, we're trying really hard to make sure that we're looking at quality measures. We do report our dollars and cents on a regular basis to the ministry. There's lots of very clinical indicators, falls, medications used, wounds, all those types of things, but we feel it's really important, and we're implementing using the quality of life tool that's measured by InterRI. And for our organization, it has an option that we can also use for long-term care that has some standardized metrics that you can measure against, some benchmarks, as well as for my independent living. So because our organization spans a few areas of seniors care, understandably there's much more than what we provide, but quality is very important to us, and more than just the amount of time spent or the medications used or the quality metrics, but are they enjoying their food? Are they participating in family engagement activities? Do they have a friend in the building? Do they connect with their care worker? Those types of things are important to us.
Mm-hmm. Let's take one last question before we get to the close of the session. Have the deaths from COVID-19 in BC brought attention to the delivery of palliative care in long-term care settings?
Mm-hmm.
I'll let you go, Dan. You're probably better at this than me, but I'd just say quickly, palliative care has been really forefront in our mission from person-centered care at Fairhaven for a number of years. So we've been working very closely with both health authorities, Fraser Health and Vancouver Coastal Health, to ensure that we implement a palliative approach to care in our care facilities. And we've got some really focused palliative care activities that go on. So COVID hasn't raised it differently. It's always been a focus for us. Dan, maybe you can add more.
Yeah, I echo that. I think in the past number of years, it's certainly gotten better. But I would say from personal experience, from my own grandma, the kind of care she was getting in the long-term care home where she was living was not the same kind of palliative care that she got in the palliative care unit at the hospital that she passed away in. And I believe that if you can get that kind of care in one building, you should get it in long-term care. And I think that particular example for me highlights the fact that older adults in care, I don't believe have the same rights as older adults in other settings. And I think we should have the same level of palliation, the same level of care, the same staffing levels, a higher staffing levels. We should have more palliative care physicians. We should have more resources. And long-term care homes are not built. The kinds of homes that we have, the one that Isabel was talking about in the Netherlands, that is certainly built for for palliation. But a small room where your family can't gather around your bed, it's hard to do palliative care in the same way. So I think we do the best we can. It's improved tremendously. And I've never heard complaints from family members about how we do palliative care. However, I think there's an opportunity to improve end-of-life care.
Okay, thank you, Dan. So we have come to the end of time for this session. So I would like to take this opportunity to thank our excellent panel, the speakers, for sharing their experiences, insights, and wisdom. Thank you so much. And thank you everybody for joining the session and asking lots of good questions here. I wish we had more time to go on because this is such an important topic, obviously. But I think I'll just echo one thing that many of you have mentioned, and Isabel certainly mentioned in her final comments about the importance of leadership and will, that there has to be political will to make changes. And this is a rare opportunity that we have, but the important thing is to seize this opportunity in the next few months to make some meaningful reforms. Otherwise, there's a chance that we may really make some incremental changes which wouldn't be meaningful and which wouldn't really make justice to the crisis that we have been going through. So with that, I will turn it over to Ruby to make final comments. Ruby, over to you.
Thank you, Habib, and to the panelists. I have the pleasure of saying a few thank yous, and what I want to do is just share as a family member with my dad in a long-term care right now in Burnaby. The first thank you I want to say is for all of the healthcare workers and administration and anybody that's working in this field. For the hard work that you're doing. And obviously many people, this is a huge interest and passion and concern for people. We still have 150 people on this call. So thank you first and foremost to you. And then of course, thank you to everybody, all my colleagues who helped put this together. So of course to Habib, who is again the chair of SFU Gerontology, and I have such a pleasure to work with him and his team. So thank you to them. And thank you to SFU Public Square, including Janet, Seth, Chloe, Doug, Jeff, Kim, and Rachel, who are all behind the scenes, and to amazing colleagues in the advancement and in our Faculty of Arts and Social Sciences. Again, Jesse Williams, Nicoletta, Tracy, Anne, Rory, Carrie, Shelley. I want you to know that there is going to be a blog that Thomas Jenkins, who's a PhD student in gerontology, is going to be putting together, and all the resources that you have heard about, so including a link to the A Billion Reasons to Care that came out earlier in February that Isabel McKenzie, the Senator's office, put out, and any of the other resources that were talked about today will be at the SFU Public Square website. So thank you to everybody for coming today, and please take care, and please refer to the blog once it's done in case you want to share that with anybody to continue this conversation. Thank you.
Thank you.
Thank you.
Thank you.
Stay well.
Thank you.